It's myself, Dr. Grace Wright, consultant rheumatologist in New York City and president of the Association of Women in Rheumatology. Laura Coates joins us from University of Oxford, UK, and Sophia Ramiro from Leiden University Medical Center in the Netherlands. So we'll have a fantastic discussion at the end of this. Seems like my slides are not advancing. There we go. So these are our disclosures for myself, Sophia, and Laura. So all attendees will be on mute for the duration of the meeting. And as I said, you can submit your questions at any point in time. Don't wait for the very end. And if you have any technical difficulties, use the chat box for those communications. The Q&A function is what we're going to be using to manage the questions for the speakers. So our agenda today includes the introduction that I just went through. There will be a review of the latest data in rheumatoid arthritis conducted by myself, followed by psoriatic arthritis updates conducted by Professor Laura Coates, and then the updates in axial spondyloarthritis by Dr. Sophia Ramiro, at which point we'll end with a discussion for all three of us, and then we'll have our summary and close. So be sure to start writing those questions as quickly as possible. So let's start with the highlights from ACR 2023, looking at the rheumatoid arthritis data. Some very interesting highlights were presented there, and I'm going to start with upadacitinib, and we'll segue into filgotinib. Now, there's been a lot of discussion about the safety of the JAK inhibitor class. And really what's nice is that we now have data over longer periods of time, but we also have data in real-world settings looking at effectiveness. And this is an example. This was 0424, real-world effectiveness of upadacitinib in patients with moderate to severe rheumatoid arthritis, the 6-month data from the observational UPHOLD study. So UPHOLD is an ongoing international observational cohort study of upadacitinib naive adults with moderate to severe RA who received UPA 15 milligrams once daily. And this interim analysis examined data from the start of the study to 6 months, reporting the proportion of patients achieving a DAS28 CRP remission, defined there as that DAS level of less than 2.6 at 6 months, as well as a proportion of patients achieving low disease activity as defined by DAS CRP with an LDL of less than or equal to 3.2, again at 6 months, as well as the change from baseline to 6 months in many patient-reported outcomes. So on the right side, you'll see the proportion of patients who achieved DAS28 CRP low disease activity and remission at 6 months using both an NRI or non-responder imputation method or an as observed, marked here as MNRI and AO analyses. So of the 1,715 patients who received UPA, 13% discontinued the study before 6 months, with the most common reasons being two things: lack of efficacy, around 4.2%, and adverse events, again at around 4.2%. Now, of the patients included in this modified full analysis set, 44.5% and 55.7%, and that's using the MNRI and as observed analysis, respectively, achieved a DAS28 CRP remission, and this again is at 6 months. If you look at the low disease activity numbers just below that, those numbers respectively are 56.3% for the MNRI and 70.6% for the as observed. And so that's what we see shown here on the left side, MNRI being here on the left and as observed being here on the right, with the higher numbers being in the as observed groups. 36.4% of all patients reported an adverse event, but there were no major adverse cardiovascular events reported, again, over the course of the 6-month period. So the UPHOLD cohort really suggests that UPA is effective for the treatment of moderate to severe RA in real-world practice, with almost half of patients achieving remission, again, as defined by DAS, at 6 months. So really giving us a flavor of the potential in the world in which we practice. I always say that RA patients are muddy. We come in with lots of different issues, and so nice to have a real-world effectiveness data set. Now let's flip to filgotinib. And this is now an integrated safety analysis of filgotinib in patients, again with moderate to severe active rheumatoid arthritis, with a maximum exposure of 8.3 years. This data comes from the clinical trial series, and you'll see that it includes both phase 2, phase 3, and the long-term extension studies, Darwin 3, phase 2, and Finch 4, phase 3. And this included patients who were treated with either 100 milligrams or 200 milligrams of filgotinib. Now, as a background, how is this different from upadacitinib? Well, filgotinib can be described as an oral Janus kinase 1 preferential inhibitor approved for the treatment of moderate to severe active RA, not available here in the US, but available in many other regions of the world. So we'll have data coming in there from real-world data sets later on. So the as-treated population here included 3,691 patients, giving us over 12,000 patient years of exposure, 12,541 to be precise. And what was seen was that there were small numerical differences observed between filgotinib doses when it comes to the exposure-adjusted incidence rate of adverse events. In fact, there are numerically higher incidences of non-melanoma skin cancer, herpes zoster, and all-cause mortality reported in the filgotinib 200 milligram program versus the filgotinib 100 milligram dosing. The incidences, however, of these major adverse cardiovascular event and serious infections were numerically lower with filgotinib 200 versus 100, with overlapping confidence intervals, just giving you a sense of the sensitivity of that analysis. And over the course of 240 weeks, the risks of MACE and VTE were comparable for both of these doses, Filgo 100 versus filgotinib 200, although the low event numbers that were seen in this program make interpretation difficult. It's really always difficult to assess where we are when we have very low numbers. The risk of herpes zoster was higher, however, with the 200 milligram dose compared to the 100 milligram dose. And when we're looking at serious infection and all-cause mortality, that was in general similar across those doses. So in conclusion, the authors of this analysis numbered 1325, so that dosage difference in patients treated with filgotinib showed small numerical differences in the exposure-adjusted incidence rates of selected adverse events between the dose groups in the overall population. So again, some helpful information in terms of, is there a dose effect? And if so, where do we see that? Coming back to upadacitinib, we're now going to look at the Select Choice study. This was number 1326, and this was the safety and efficacy of upadacitinib in patients with rheumatoid arthritis refractory to biologic DMARDs, giving us results through to week 204 from the Select Choice study. Now, Select Choice, interesting design, examined the use of upadacitinib at a dose of 15 milligrams, that's labeled UPA 15, UPA 15, in RA patients refractory to biologic DMARDs. So this was a bio-DMARD experienced population versus intravenously administered abatacept. And period 1 in the study is a 24-week phase 3 double-blind trial. Period 2 is an open-label long-term extension where patients initially randomized to abatacept were switched over to daily upadacitinib 50 milligrams at week 24, and then patients initially randomized to upadacitinib 15 milligrams continued to receive that for up to 4 years. So this is really a crossover. Abatacept goes to upadacitinib remains on upadacitinib, and we see what happens over the course of 4 years. So this was designed to, again, look at the long-term safety as well as efficacy in patients with RA up to this 204-week endpoint for those treated with upadacitinib at the end. So the key results shown here are of the patients who entered the long-term extension already on UPA, 151, which is about 27.6% of patients, discontinued treatment, with the most common reasons being adverse event, and that comes in at about 9.1%, right? 63.5 and 83.0% of patients on continuous UPA achieved or maintained a DAS28 CRP of less than 2.6 or 3.2 respectively at week 204. So again, the more stringent measure of being less than 2.6 at 63.5 and less than or equal to 3.2, 83%. Again, looking out over the course of the 4 years. 38% of patients achieved a CDI remission, and 80% achieved low disease activity by this metric at week 204. And then at week 204, again, if you look at the ACR 20, 50, and 70 responses, the number of patients, the percentage of patients who achieved those thresholds were 90, 75, and 58%. So again, across this time course of 4 years. And then across all the efficacy endpoints, similar results were observed in patients who switched from ABA to UPA compared to those who continued on UPA from day 0 in period 1. So continuous on UPA 15 milligrams. And no new safety signals were identified following exposure over the course of this week 204, again, adding to the data that we see with the rest of the SELECT clinical trial program. And so this data from SELECT Choice further supports the long-term safety and efficacy of UPA for the treatment of patients with rheumatoid arthritis. Now let's talk about some other pathways. So here we're going to look at the IRAK pathways, and R851 is the focus here. And this is a potent second-generation IRAK1 and IRAK4 inhibitor, which suppresses IL-6 in vitro and in vivo for the treatment of rheumatoid arthritis. So really thinking about other signaling pathways that may be important or may be beneficial for our patients. So when we have toll-like receptor activation, what is the signaling sequence that follows from there? Well, what happens is there's an induction of IRAK proteins, which then results in the activation of the interleukin-1 receptor family signaling cascade, and that can drive chronic inflammatory responses. So inhibition of IRAK4 has already been investigated as a novel therapeutic strategy for the treatment of rheumatoid arthritis. This molecule, a small molecule, R835, inhibits both IRAK1 and IRAK4 and has been shown to attenuate lipopolysaccharides or LPS-induced inflammatory responses in human volunteers. So these are human volunteers. We're not looking at a cohort of disease activity in RA patients. So the analog R851 has been modeled to require a 5-fold lower dosing for a similar efficacy as R835, making it potentially suitable to treat chronic inflammatory diseases such as rheumatoid arthritis. So this is really about how do we fine-tune a molecule based on pathways that may be activated by particular, as I call them, immunological instigators. How do we find a disruptor that can give us the pharmacokinetic profile that may be useful in human studies? So the data shown here on the right is giving you this using IL-6 as a readout, the percent inhibition. And so we'll see here, just using your control, equivalent to your placebo or your vehicle, you have a certain amount of IL-6 present. And the idea here is to look at dose dependence, as you see here, R851, 5, 15, and 45 milligrams as part of the inhibitory profile. And this then showed a dose-dependent, linear, and predictable pharmacokinetic profile in multiple day dosing in animal studies. So a really great first step. And R851 is expected to require 5-fold less exposure for a similar effect of R835. So we can really down dose and still get an equivalent level of potency. Whole blood assays have demonstrated a 7 to 10-fold improvement in the potency of R851, driven by reduced plasma protein binding. And then when we went now to whole animal models using an in vivo mice model, these mice treated with R851 have shown robust inhibition of interleukin-6 secretion following IL-1 beta stimulation. So really looking at models to define how does this work, and then we can look across various dose ranges to see is this something that is potentially viable. So the summary here is that this small molecule R851 may offer an efficacious treatment for chronic inflammatory conditions such as rheumatoid arthritis. We'll see whether it's restricted to that through this pathway of the IRAK1 and IRAK4 inhibition. So just some new insights into potential new therapeutic strategies. And then coming back to filgotinib, looking at cardiovascular and malignancy events in the filgotinib rheumatoid arthritis clinical development program, again up to 8.3 years. And this is a number you'll see here, 1343, if you want to go back, presented on Monday. So really giving us a much more granular breakdown on some of the numbers that I mentioned earlier. So this is post-marketing data that we saw in the oral surveillance trial, looking at tofacitinib versus adalimumab. And the cohort there was defined as active RA patients aged greater than 50 years with at least one cardiovascular risk. 50 or older, you could be 50 with at least one cardiovascular risk. And so looking at this in our patients now with filgotinib, the risks of cancer and MACE were higher with that pan-JAK inhibitor compared to the tumor necrosis factor inhibitors used there, etanercept and adalimumab, with higher rates noted in those who were 65 and older compared to those who were under 65. So the point of this analysis now is to look across the 7 clinical trials. You'll see here Darwin 1-3, Finch 1-4, to determine the incidence of malignancies in patients treated with either 100 milligrams filgotinib or 200 milligrams filgotinib. On the right side is a plot that we are sort of now quite accustomed to looking at, and you'll see it's divided by MACE, VTE, malignancies excluding non-melanoma skin cancer, non-melanoma skin cancer, and treatment-emergent adverse events leading to death at the very bottom, with these various age fractions shown here. So less than 65 are the first two, and it's 100, then 200, 65 or older, 100 and then 200. And this motif is repeated down the line for these groupings for these 5 different analyses. By looking at the point estimates and the overlapping confidence intervals, we can get a general sense as to whether there is a difference between these as well as between doses and then again between age groups. So there were 3,691 patients treated with filgotinib for a total, again, of 12,541 patient-year exposure. And overall, the event exposure-adjusted incidence rate was 0.4 for MACE, 0.19 for VTEs, 0.69 for malignancy, excluding NMSC, and then 0.29 for NMSC, and 0.65 for the treatment-emergent adverse events leading to death. For MACE and VTE, these exposure-adjusted incidence rates were higher in patients who were 65 or older compared to under 65, but were generally similar between the 200 and the 100 milligram group within each age group, really shown here when you look at the under 65 and the over 65. So the results of MACE and VTA in filgotinib treated patients were low and similar across both doses, 100 and 200, and the EAIRs of malignancies, non-melanoma skin cancer, and treatment-emergent adverse events leading to death were higher with the 200 versus the 100 group in patients who were 65 years or older, although as you'll see, the confidence intervals were overlapping. So again, we'll have to take that into consideration. Finally, we look at peresolimab. This is a cellular and proteomic changes following administration of peresolimab in a phase 2A trial in rheumatoid arthritis, presented on Tuesday, number 2176. Now, as a background, peresolimab is a humanized immunoglobulin as an IgG1 monoclonal antibody that stimulates the human programmed cell death protein 1, or PD1, as we'll shorten that to say. This was a phase 2A double-blind randomized controlled trial that has already shown superiority to placebo with respect to improvements in the DAS28 CRP scores in patients with moderate to severe RA. So this particular study now examined blood, serum, and plasma biomarkers that were identified during the trial in 98 patients who received peresolimab or placebo for 12 weeks. Samples were collected at time points ranging from baseline up to week 14. Summarizing those results, we see here that peresolimab treatment reduced the number of peripheral CD4 positive, PD1 high and PD1 interim low. Here we'll see cells by 53.6 to 57.7% and 33.8 to 38.5% respectively. So here we see a high and intermediate CD4 positive cells. There was a down modulation of cytokines and chemokines and interleukin signaling pathways noted after treatment, including IL-6, starting at week 8. And then protein analysis suggested that molecular pathways that are altered in patients with RA trended towards healthy subjects following peresolimab treatment as early as week 8, really shown sort of at this time point. Following treatment, so corresponding with the timing of what was seen in the DAS28 improvements. So giving us some further insights here into how this version of interrupting the inflammatory pathway may be helpful. And so cellular PD-1 inhibition with peresolimab in patients with RA correlates again with clinical inflammatory changes. So again, a nice point of a fact here that may be useful going forward. So that wraps up for me the highlights from ACR 2023 for rheumatoid arthritis. And we'll now turn and introduce our next speaker, Dr. Laura Coates. Dr. Coates is an NIHR clinician scientist and senior clinical research fellow at the Oxford Psoriatic Arthritis Center. She's also a member of the steering committee of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, or GRAPPA, and the British PSA Consortium, or BritPath. Professor Coates has been involved as either the primary author or co-author of over 400 publications, chiefly in the areas of rheumatology and psoriatic arthritis. So I now, with great pleasure, turn the slides over to Dr. Laura Coates.
Lovely, thank you very much. So it's great to talk about this. It's all very much fresh in our minds, as we're pretty much fresh off the planes. So it's great to share this data and bring back some highlights for you. So the first study I'm going to talk about is a study of intravenous secukinumab. And you'll see later on Sophia sharing the data for the ankylosing spondylitis trial. This is testing the efficacy and safety of intravenous secukinumab in active psoriatic arthritis. So obviously we are used to having subcutaneous secukinumab for treatment of psoriatic arthritis, but this is an intravenous version of the same drug. And patients were randomized to have an initial loading dose at 6 milligrams per kilogram, and then continued on at 3 milligrams per kilogram in the long term, or obviously half the patients got placebo out to week 16, which is where the primary outcome was. So you can see in the graph on the right that there's a higher proportion of people achieving good outcomes. ACR 50 is the primary outcome with secukinumab compared to placebo, and that was maintained out over time, so there seemed to be a good ongoing response. And as you'd expect, the placebo patients caught up once they were started onto treatment. So it does look like intravenous secukinumab is going to be a good, safe and effective medication. This potentially obviously has a benefit because this is dosed per kilo. So in some of our patients who are overweight, this may be a good option to get a slightly higher dose into patients who are heavier. And I think it probably has particular use in the US because of access to intravenous medications. But is probably less likely to be used in the UK and Europe. So this drug is now moving forward for approvals. Bizarrely, with some slightly odd regulatory decisions, it's going to be approved at a lower dose than was shown in the trial. The FDA have required some modelling and have actually dropped the dose. So I think the key thing going forward will be to look at what the efficacy looks like in real life, because it actually won't be the same dose as this trial here. It will be about half the dose of, in maintenance. In terms of other treatments, so obviously bimekizumab, we now are starting to see approved in varying countries across the world for psoriatic arthritis. We've had 2 positive phase 3 trials in psoriatic arthritis and also in AXPAR patients. So this abstract looked at really the data from both groups, the AXPAR and the PSA studies, and tried to summarize all of the improvements across the key GRAPPA domains for psoriatic arthritis. So in GRAPPA, we think about peripheral arthritis, psoriasis, enthesitis, dactylitis, skin and nails. Obviously, in the psoriatic arthritis studies, we get a lot of the data across those different musculoskeletal outcomes and with the skin. And then from the ACR studies, we get good data around spinal disease and the response for the AXPAR patients and any patients who also had psoriasis. And to date, in these studies, there were no reports of uveitis in the initial 52-week study, and then just 2 patients who had a definite adjudicated IBD. So obviously, there's probably a selection bias here. I think we're less likely to put patients who have possible IBD or symptoms of bowel disease into a study with an IL-17, because we know that that's potentially a risk. But there was some nice data as well looking at uveitis and suggesting this drug may reduce uveitis, which is something that we haven't seen with IL-17A. So maybe something that's a bit different about this drug showing efficacy in uveitis as well. But certainly good data across the key 6 domains of psoriatic arthritis. And then a couple of abstracts around risankizumab. So this is the IL-23 inhibitor. It's a specific IL-23p19 inhibitor, which has been approved for the treatment of psoriatic arthritis. And that was based on 2 trials, KEEPSAKE-1 and KEEPSAKE-2. So this initial data is from the KEEPSAKE-2 trial, and this is long-term data. You can see out to 148 weeks now from the original patients included in the KEEPSAKE-2 trial. And we can see good ongoing efficacy, so very good maintenance of response. The primary outcome in terms of ACR and also with MDA outcomes showing a good maintenance of efficacy out at 3 years, and similar to the efficacy that we saw at 1 year and at 2 years. So we've got good data suggesting that these drugs keep working and show durable efficacy. Just to zoom in on the table here and show you some more of the data, you can see here the response rates for enthesitis and dactylitis, again maintained through that 3-year period, changes in patient-reported outcomes, and as we'd expect with a P19 inhibitor, very good skin outcomes with very high PASI 100s here of sort of 50 to 60% for the patients treated here. And obviously, as well as efficacy, we want to know about longer-term safety, particularly with newer drugs like the IL-23 inhibitors, but there is no new safety findings seen in that 2nd and 3rd year of the study, and looked very similar to the initial placebo-controlled trial. And if you go back and look at those earlier studies, it's clear that the rates of safety signals are very low with risankizumab and with other IL-23 inhibitors. So these do seem to be drugs with quite low rates of treatment emergent adverse events. And then this is very similar data from patients in the KEEPSAKE-1 trial. So this was the other phase 3 trial. This is in patients who were conventional DMARD failures. So these are biologic naive. And again, good maintenance of response. So you can see here the ACR 50 on the right-hand side. As we'd expect, the as observed rates are a bit higher than the non-responder imputation because people will drop out of the studies over time. And obviously that's more likely to happen if they're not responding. So the more conservative non-responder imputation is shown in the purple underneath. But the as observed for those who did stay on drug, in terms of thinking about people maintaining their therapy, slightly higher. And again, this was seen across the domains. So similar good maintenance of efficacy out to 3 years for skin disease, for enthesitis and dactylitis, and a very low rate of radiographic progression. Obviously, in the longer term studies, we don't have a comparator. The placebo arm has gone, but we're seeing very low rates of radiographic progression overall, which is quite typical in these psoriatic arthritis studies. And again, pretty low rates of treatment emergent adverse events that seem very similar to the previous studies. So these do seem to be drugs with quite a good safety profile. The next drug we're going to talk about is a drug called izokibep, which always sounds very upbeat, I think, in a name of drug. This is another IL-17A inhibitor, but it's a little bit different because it's a nanobody or a small molecule. So it's much, much smaller than a traditional monoclonal antibody like secukinumab and ixekizumab, which block IL-17 just the same. So it's aiming to block the same thing, but there's at least some theoretical benefit to having a small molecule that may be better at penetrating into tissues, and with an albumin binding site may get into tissues a little bit better. And in particular, there's been some interest about whether this may be beneficial in enthesitis. So this is a relatively small trial. It's still a phase 2 trial. We haven't got phase 3 data yet, but patients were randomized to receive either 40 or 80 milligrams of the izokibep. And there was an initial placebo arm to week 16, and then they switched on to the higher dose of izokibep. So we've seen the primary data reported before, which looked very good, and probably quite consistent with what we see with IL-17A inhibitors, maybe with a slightly higher response in terms of enthesitis. They did see quite a good rate of enthesitis resolution, but it's always a little bit tricky in a small phase 2 trial to be confident about that, how that's going to compare in the long term. So I think we probably do need the phase 3 to get the best idea. But this is showing some longer term data out beyond week 16, just to look at stability in scores, really. So most of the patients achieved ADAPSA low disease activity or remission outcome by the time we got out to week 46. Similarly for MDA, around 60% or even higher who achieved minimal disease activity. And those high enthesitis resolution rates that were seen at week 16 also seem to be maintained out over the initial year of the study. So I think some very positive data still in phase 2, and it will be very interesting looking forward to see what we get in phase 3 trials of izokibep, and whether we can see real differentiation for this being a different molecule, or whether it's going to show quite similar outcomes to other IL-17A medications. And then finally, this is the data on the foremost study. So this is a placebo-controlled trial in oligoarticular psoriatic arthritis. This is not the normal population that get into drug trials. And these patients were treated either with placebo or with apremilast. So a few slightly odd things about the study. So they defined oligoarthritis based as patients who had between 2 and 4 swollen joints and between 2 and 8 tender joints. So potentially they could have had up to 8 joints if the swollen and tender joints were in different places. Actually, in the end in the study, nearly 90% of them were what we would consider, I think, a true oligoarthritis, where they had 4 or less active joints that were either tender or swollen. And the primary outcome for this study was the minimal disease activity score, but using a slight variation where you had to achieve the joint outcomes. So you had to achieve a tender joint count of 1 and a swollen joint count of 1 or less. And then the other slightly unusual thing is that they used what they're calling a sentinel joint count. So they counted joints that were active at baseline and then followed up those same joints to look at MDA control at week 16. So this is only the joints that were involved in baseline that fed into the primary outcome. So you can see here, MDA joint response was significantly more likely with apremilast, 34% compared to placebo at 16%. Similar outcomes in other disease activity measures. And actually the standard MDA performed basically the same. But interestingly, there was quite a difference in joint counts over time. And this is where this sentinel joint count gives you slightly different data. They did present both the sentinel joint count and the full joint count. But if you look at the graph on the right-hand side, you can see in a relatively short space of time, this is only a 4-month trial, there's quite a big progression in patients who've gone from a true oligoarthritis of 4 or less joints to patients who have more than 4 joints. That was a lot more likely in placebo, so around 35% of the patients evolving into a polyarthritis, compared to around 20% of those on apremilast. And certainly for most of us in the field, we felt that this seemed like quite a lot, quite a high proportion compared to what we see in clinic. But obviously, hopefully, we're not treating most patients with placebo, and maybe this is what we would see if we weren't giving patients treatment in clinic. But definitely a really interesting study taking a look at this very understudied population of oligoarthritis and in early disease, which I think will be really interesting to dig into a bit further and learn more about this cohort as we look at some of the secondary outcomes in the data. So that's it for my psoriatic arthritis highlights. I'm going to hand over to Sophia now for the Axial SPA data.
Thank you, Laura. That was fantastic. And I'm just going to introduce Dr. Sophia Ramiro. She's a consultant rheumatologist and senior researcher at Zuderland Medical Center. Dr. Ramiro also has an appointment at Nova Medical School in Lisbon as a visiting professor and is a member of the executive committee of the Assessment of Spondyloarthritis International Society, or ACS. And she's been involved in many EULAR task forces for the elaboration of recommendations, including on the management of axial spondyloarthritis. So with that, I welcome Dr. Sophia Ramiro back to the floor. Thank you, Sophia.
Thank you very much, Grace, for this kind introduction. It is my pleasure to be with you reviewing this fresh data on Axial SPA from this Congress. And I think my task will be a little bit easier because Laura Coates has already covered several data that apply to PSA and also to Axial SPA. So you will hear some of the same molecules coming back because there's novelty in both diseases. Bimekizumab is one of them to start with that we have heard already, and it's a monoclonal antibody that selectively inhibits IL-17F in addition to IL-17A. We have two phase 3 studies, BMobile 1 and 2, that have shown efficacy of bimekizumab in both non-radiographic and radiographic axial SPA. And in this first abstract, we have seen our authors, Philip Mies and colleagues, have shown us a deeper look into patient-reported outcomes. I'm aware that the graph is very small, so I will zoom into it so that we can look at it. On the left-hand side, we have BMobile 1, so patients with non-radiographic axial SPA. On the right-hand side, BMobile 2, radiographic axial SPA. And we can see on the top, we look at spinal pain at night with a significant improvement at the timing of the primary endpoint, 16 weeks, that was sustained up to week 52. And we see similar patterns for the other outcomes, namely the second one is total spinal pain, and the third one is morning stiffness as assessed by the BASDAI. Another very important patient-reported outcome that was looked into is fatigue. There were higher levels of improvement of fatigue with bimekizumab compared to placebo. And on the right-hand side here in the graph, we are looking at patients that have a meaningful improvement in the FACIT score in fatigue, so an improvement of at least 8, and we can see that there is a higher improvement with bimekizumab, in both non-radiographic axial SPA and in radiographic axial SPA. So if we take all this into account, we see and conclude that bimekizumab resulted in clinically meaningful improvements in patient-reported outcomes such as spinal pain, morning stiffness, and fatigue at up to week 52 in both non-radiographic and radiographic axial SPA. Continuing in bimekizumab, but now looking at a different trial, a different study population, and I think it's quite important when a new drug comes to the market that we have information about, or we look clearly into the performance or the efficacy of the drug in those patients that were naive to previous treatment or that have failed previous treatment with the TNF inhibitors. And that is exactly what was done in this abstract. In this abstract, both data from both trials was pooled. So from patients with non-radiographic axial SPA and radiographic axial SPA, and we are looking at pooled data together. Here on the graph, we have data on the primary endpoint, ASAS40 at week 16 to start with. And we see on the left-hand side patients that were TNF inhibitor naive. And we see that a higher response was seen, so 46% compared to 23% patients in bimekizumab compared to placebo, and this response actually even increased up to week 52. On the right-hand side, we have patients that had failed TNF inhibitors, and here we also see a higher response with the bimekizumab at week 16 that was sustained and even slightly higher up to week 52. And another very important outcome, likely even more important when we are thinking about our daily clinical practice, is achieving low disease activity. And that is what we see here again on the left-hand side in patients that were naive to TNF inhibitor with a higher response or higher achievement of low disease activity at week 16 with bimekizumab that was sustained and even slightly higher until week 52. On the right-hand side, we also see in patients who were insufficient responders to TNF inhibitor, we also see a higher response with the bimekizumab compared to placebo. We see a slight dip exactly at the timing of the primary endpoint at week 16. Those are 7 patients that at week 12, they achieved low disease activity, at week 16 not, and at week 24 again. Those are all patients with radiographic axial SPA and all males. And I have shown you data on disease activity, but there's also improvement in other outcomes, such as quality of life, function, in which bimekizumab has shown to achieve higher responses in patients, both TNF naive and TNF insufficient responders. And quite surprisingly, in terms of this data, is that we see similar responses in patients that are naive to TNF or that were insufficient responders. And this is not what we have been seeing from other trials where the TNF inhibitor population that has failed to TNF inhibitor is usually a more difficult to treat population. So in conclusion, bimekizumab treatment resulted in clinically meaningful improvements in key efficacy outcomes and in all domains that are important of the disease. Now moving to a different drug, and now we are talking about, we have a poster presented on tofacitinib, and I think this is a quite interesting study, admittedly with some limitations, but I will explain to you why I think it's important. When we are nowadays tapering drugs, when patients achieve a state of remission and particularly sustained remission, that's also in our recommendations, recent recommendations as EULA recommendations to do that, but on purpose we have only issued recommendations in terms of tapering biological DMARDs. This because we do not have any data on JAK inhibitors. This is a study that was conducted in India. It's not a randomized control trial, and therefore it has limitations, as I was mentioning. But in India, tofacitinib is widespread use. They have already generic of the tofacitinib. And so what they did is that in 54 patients that had achieved low disease activity or actually remission in active disease, others below 1.3 or below 2.1 for at least 3 months, then they tapered tofacitinib. There's no comparator arm, so this is purely descriptive. But what we see on the right-hand side in the Kaplan-Meier curve is that at 18 months, the median time to flare was at 18 months. So we see here approximately at 50% corresponds to 18 months. Tapering was at the discretion of the physicians. 43% of the patients flared, but importantly, when treatment with tofacitinib was restarted, all of them re-achieved the state of low disease activity or inactive disease that they had. Authors also looked at factors associated with flares, and they identified patients with radiographic axial SPA, so radiographic disease, prior use of conventional synthetic DMARDs, or a very high disease activity with an ASAS above 3.5 prior to treatment, as factors associated with a higher likelihood to flare. So a first indication, although with limitations, as I mentioned, but that eventually it might be possible to taper tofacitinib. We see a high proportion of patients with flares, but tapering was also quite fast. And we also see that patients were only in remission or sustained remission actually for 3 months, which also may be a short period of time. Moving to another drug, also already previously presented by both speakers, actually, upadacitinib. We now also have more new data in Axial SPA. We have 2 trials, Select Axis 1 and Select Axis 2. And previously, efficacy of upadacitinib had been shown at week 15 and in different trial populations in patients with radiographic Axial SPA, BD-MARD naive, or BD-MARD insufficient responders, and also non-radiographic Axial SPA, and efficacy is sustained up to week 52. But here, what was considered or was specifically looked is in those patients that respond at week 14, so not all patients, but the responders at week 14, what is the proportion of them that respond or that are still responders at week 52? And in summary, the proportion is very high. As we can see, you can see here on the graph, it's a quite busy graph, and I will guide you through this. On the left-hand side, we have ASAS 40 outcomes. On the right-hand side, we have an ASAS partial remission. And then we have 3 colors. Green color is BD-MARD naive radiographic Axial SPA. Purple is BD-MARD insufficient responder radiographic Axial SPA. And blue is non-radiographic Axial SPA. And then we have the first 3 bars are as observed data. So we see that of those patients that had achieved an ASAS 40 at week 15, 87% of them achieved at week 52 or were still at week 52. And similarly high percentages or even higher in the other 2 populations. Then we have here some striped graphs, and they are non-responder imputation for the first population. The two following populations, it's a mix of non-responding imputation, but also with multiple imputation due to several losses due to COVID-19 pandemic and the periods of lockdown. On the right-hand side, we have the ASAS partial remission, and I think we have a similar picture. So with a high persistence of response in those that achieve response at the timing of the primary endpoint. Here it's another graph now looking at ASDAS outcomes, starting with low disease activity, inactive disease, and then the response, the clinically important improvement, a major improvement, and in all of them, except inactive disease, but I will start with the other ones. You see very high percentages of those achieving the responses at week 14 and keeping them at week 52. Inactive disease, ASDAS inactive diseases and ASDAS below 1.3 is a very stringent outcome, and as expected has slightly lower response rates here. So patients treated with upadacitinib with a clinical response at week 14 experienced sustained improvements in disease activity, patient-reported outcomes and function. Other outcomes, I haven't shown you the graphs, but it's a similar pattern at week 52. So we see a sustainability of the response. Also, something that has been presented before by Lara on a PSA, we have now in radiographic Axial SPA, namely the efficacy of in intravenous secukinumab. We indeed have secukinumab subcutaneous, but now it has been tested in intravenous, both in radiographic and non-radiographic Axial SPA, and we see that it has been shown to be superior to placebo, so meeting the primary endpoint, and as expected, meeting not only the primary endpoint ASAS 40, but also several other secondary endpoints as are listed here in the slide. On the graph on the right-hand side, you can see the primary endpoints at ASAS 40 with a statistically significant response at the primary endpoint, week 16, that was sustained up to week 52. And in terms of safety, we did not see a different safety profile than what we already know for secukinumab. So in summary, we have another treatment option potentially available for our patients. It may be questionable which is the trial population in which we will use it, as Laura already mentioned, probably more to be used in the US. But then sometimes there are patients that have problems of compliance, and in those that can be an intravenous option can be an alternative. We already have heard a comment from Laura on the low rate of the uveitis with bimekizumab, and here we have a specific abstract looking at it in Axial SBA. It shows pooled results from phase 2b and 3 trials, so both phase 3 trials with non-radiographic and radiographic Axial SBA, and we indeed see a low occurrence of uveitis with bimekizumab. Of course, we have some limitations in assessing this. Not all patients have uveitis. It's a trial that is not specifically designed for it, and we have a short period of placebo-controlled. But in the double-blind treatment period, there were 11 patients that were randomized to placebo that had a uveitis, compared to 2 that on bimekizumab that had a uveitis. So it's a different, it seems to be a different incidence in these patients. And if we look at patients that had a previous history of uveitis, so in the placebo randomized patients, which were 19%, we see that uveitis occurred in 20% of them. And in the bimekizumab patients with previous history of uveitis, which were 15%, uveitis only occurred in 1.9%, and we know that it's exactly in patients that already have a history of uveitis that they have a higher likelihood of having another episode of uveitis. On this graph here on the right-hand side, we see the same. We see on the top the double-blind treatment period, all patients with an exposure-adjusted incidence rate of 1.8 on bimekizumab compared to placebo 15.4 exposure-adjusted incidence rate, so per 100 patient years. And then when we look at patients with a previous history of uveitis, those that have a history of uveitis on placebo have a much higher incidence compared to those on bimekizumab. So the incidence rates of uveitis was lower at week 16 in patients with bimekizumab compared to placebo. And a last slide on a study on a molecule that has not come up today yet, ixekizumab, and an IL-17A inhibitor. And this is a post-hoc analysis looking specifically on structural lesions of the sacroiliac joints in patients with radiographic axial SBA. So we know that ultimately we would like to show that our drugs are able to inhibit progression of structural damage. With the conventional radiographs, we have limitations because we do not capture damage earlier than 2 years. So now this is an analysis using MRI structural lesions as a surrogate for progression of structural damage. I have to give a side note that there is still some discussion in the field to what extent this surrogate is really predictive of what we will later see as structural damage. But it's good to start seeing data on it and to understand more this phenomena. And what we see here is that on the graph here, we see on the left-hand side erosions, and we see a slightly higher level of the erosions in with placebo in gray. Then with ixekizumab every 4 weeks, which is the registered dose, we see a significant decrease of erosions, and we see a dose effect, which gives plausibility to the effect. So with ixekizumab every 2 weeks, the effect seems to be more pronounced. On the right-hand side, backfill, so the repair tissue is higher with ixekizumab compared to placebo, although only significant with ixekizumab every 2 weeks. So ixekizumab treatment for 16 weeks decreased erosion scores and to some extent increased backfill, which may suggest rapid tissue repair. And this brings me to the end of the highlights of Axial SBA, and I give the word back to Grace.
Thank you so much, Sophia. That was fantastic. Really lovely to have both of these additional presentations. So I'm thanking both Dr. Ramirez and Dr. Coates, and we're now going to open this up for our Q&A session. We already have a few queued up, and we have just a few minutes. So I'm going to ask these questions for both Laura and Sophia. I think they can be overlapping. And the first one is, are the data the same for men and women?
Yeah, so this has been of real interest, I think, in the last few years. There's been increasing evidence around differences between men and women in terms of response in psoriatic arthritis. There was a lovely other abstract that we didn't show here. There was a meta-analysis of all of the trials in psoriatic arthritis. They showed differences in baseline, so women had higher tender joints, higher patient-reported outcomes, lower CRP and lower PASI. And they looked at differences in response, and in nearly every group of drugs, response rates favour men. They get a higher level of response, and that's true across the monoclonal antibodies. But in the group that included data from the JAK inhibitors and the TYK2 inhibitors, there was no difference in response between men and women. So if that holds up, I think there's still questions about that, but if that is consistent, it may really give us a bit of insight into why the differences might exist, and whether targeting the inflammation in a different way could be better for different patients.
Yeah, no, fascinating. I think we have to think about people as individual. Not everybody belongs to the same group. Anything in the axial spondyloarthritis world to speak to this? I know that's also been a huge interest recently.
Yeah, I think similar comment as Laura made, that I don't want to repeat, but I would like to say that I think we are continuously investigating the effect in gender, which is very important, but we do not have trials stratified for gender. So if we would really want to know the efficacy, because women also have higher patient-reported outcomes in general. We know that from cohort studies as well. So if we want to tackle a differential response between them, then we would need trials that are really, whose randomization is stratified for gender. And so far, I don't see many pharmaceutical companies very enthusiastic about doing that.
The first one is out there. So the first of the trials in psoriatic arthritis has stratified by sex.
Yeah, so we have a baby being born.
So people are listening.
Yeah.
Not in Axial SPA yet, but I hope so.
And then we have to make sure that our outcome measures are gender agnostic, so that when we ask the same question and it's responded to the same way, that it's actually answering the same thing. So we have some ways to go, but thanks for the update on that. And I'm just going to say in RA, we're not doing any new stratified that I have seen. So we'll have to see what data we can glean from that. But again, it's such a female dominant disease. So we'll see. And then there's a question that, Laura, I'm going to direct at you. And it was about the use of apremilast in axial PSA.
Yeah, so it hadn't been tested specifically in axial PSA, but did have a negative trial in AXPAR. So we wouldn't recommend, and the GRAPPA treatment recommendations don't suggest apremilast for anybody with significant axial disease. I think this is useful for peripheral joint manifestations and for skin disease, and obviously now has this very useful data, I think, in oligoarthritis.
So we have 0 minutes left, but I'm just going to throw out, I know everything that I've talked about for each of us was an important highlight. Any part of this that you would highlight even more for the clinical rheumatologist in terms of which data set is going to be transformative for us in the next 6 weeks? What can we do tomorrow?
I think having that initial look into oligoarthritis is really fascinating. It's going to help us understand a lot of the patients that we see in the clinic who are not represented in clinical trials. So I think it's really important to have specific data. I don't think people are going to respond hugely differently to different medications. I don't think it's a completely different disease, but I think it's a population that definitely needs studying.
And Sophia, any?
I think the low uveitis rate with bimekizumab is quite puzzling because it's something we do not see with other IL-17 inhibitors. On the contrary, so it's either that the selective inhibition of IL-17F makes a difference there, or I think we need to understand it better, and I hope we will have specific trials that designed to address this.
Yeah, no, I did find that quite interesting, and I think we'll understand more about the immunology behind all of these things as we have drug development, and then the oral IL-17, the small molecule IL-17 correctly may tell us even more. So with that, we've run out of time, sadly. I always love chatting with my fellow rheumatologists here. So just to summarize, thank you for joining us. Thank you for attending this webinar. Much more to come, and really it was a very engaging and very useful American College of Rheumatology session this time. Again, thanks to our sponsor, Lilly, for supporting this, and thank you to you, the audience, for attending. There's now a short evaluation form. Please fill that out to give us your feedback. We really appreciate that. And there's an on-demand version of this webinar that will soon be hosted on Cytokine Signaling Forum website with a host of other resources to really keep you up to date in all things within this field. So just shown here, slide resources, Congress reviews, podcast episodes, available in 6 languages, and a host of courses, 31 to be exact. You can register for these by just scanning this QR code and join us at a future date or on your own time to go forward with much of this content. So thank you once again to both Laura and Sophia for joining, for me at my lunch hour and for you in your early evening hour. Thank you so much.